staff with them. But I didn't find anybody, for what I believed would keep me somewhere when I was a therapist, but I didn't find anyone that put all of it together. And that's, again, I decided to write the book, and it was a phrase I coined, I guess back in 2003 when we first came, but it's called From the Bedside Out. Everything you do in this facility or in your facility that you're going to work with, whether it's NHC, and they have a wonderful setup over there, I mean, just first class, or whether it be out of a physician's office that does maybe a congestive heart failure clinic or something of that nature. Everything needs to start from that bedside out, or the patient out. Now, how do you think you improve care at the bedside? I mean, what would be one of the things that you would believe would help improve care at the bedside?
More time with the patient.
Pardon me?
More time with your patient.
Okay, that's a great, because I'm going to get to that. You are absolutely correct. What else would help?
Consistency.
Pardon me?
Consistency.
Right, consistency.
You need to listen to the patient's concerns and what needs to be met.
And the biggest thing, if you want to know how to improve care at the bedside, listen to you. Oh, this is where there was an article back in 1998 in Modern Healthcare magazine, kind of the Bible for a lot of the folks in healthcare administration. And it said basically that while senior management believes they are doing things that should be positive in retaining their staff, they're really not walking the talk. It's just lip service. They're just talking these things. They're not really walking it or walking the talk. And my conclusion is now, 18 years later, there's still a lot of that going on right now in this nation. There's over 6,000 hospitals in the nation. 72% of them are 200 beds or less. So when you start looking at where this will work, this model, those are perfect places it will work. And then if you get to a larger one, because I went everywhere from a 60-bed facility, and I was the CEO of a 380-bed medical center in Louisville, Kentucky, from neonatal units to open hearts to everything. It works in whatever size. You just have to gauge your infrastructure differently to make it work. But as it turns out, 18 years later, it's still not being done nationwide, and you have people with high turnover rates. There are some facilities doing it well. Obviously, this one did, but there's a number of Mount Sinai Hospital in New York and a couple others. Bethesda is another one. At the same time, when you start looking at the turnover, you have to look at why there's turnover, or did we select somebody wrong that was a wrong fit for the organization, things of that sort. But again, I think one of the things that's hurting today with the senior level actually walking the talk is there's now tremendous financial accountabilities to keep facilities open. And also there's tremendous accountabilities for patient outcomes. You realize this is the first time in the last, probably within the last 7 to 8 years, but is the first time patient outcomes and accountability for that has ever been on the healthcare system. In the 1990s, if you had a bad outcome in a hospital, you had a bad outcome. Now, the hospital might have been sued, don't get me wrong, but you just had a bad outcome in the 90s. That's it. And, for example, I mean, how much have y'all emphasized hand washing? Everybody laughs. Let me tell you a story. When I taught respiratory therapy at the Medical University in Charleston, we would take a group of therapists in to manage ventilators in one of the ICUs. There were 6 ICUs there. And we'd take them into the intensive care unit to manage, say, 4 or 5 ventilators, 6 ventilators. And if we found that they didn't wash their, this is 1978, by the way, if we found that they didn't wash their hands, because we didn't have all the ease, it's too easy now, and I'll tell you a little story about that, but they're too easy now. But if they didn't wash their hands in between patients, they got a 0 for the day, and I sent them home. They didn't wash, that was 1978. What happened 40 years later that we're still having trouble with it? It is the best, defense for spreading infections. And just like with spreading infections, you go back, everybody thinks of Florence Nightingale, your mother of nursing. Well, you know what Florence Nightingale really should have received credit for? She reduced the death rate due to infections by almost 30%. Do you know how she did it? They changed the sheets every day. That was it. Again, those are the types of folks that you really want to say, wow, that's somebody that really made a difference by what they did. And she was your mother of nursing too, but at the same time, I give her more credit for that because we're still struggling with it. And keep in mind, the bugs are winning. Everybody has to know the bugs are winning. It doesn't matter, we have gorilla selling out there, the bugs are still winning. So, again, the best defense is going to be your hand washing. So when you start thinking about from the bedside out, you need to look at where this all evolves. And all of it evolves in the fact that the different types of medicine being practiced today are, being so technical that we're not, as you said, spending the time with the patient. Now, what type of a workload, what type of a, assignment do you think you would want to have when you walk in? Now, some are already dictated. ICUs are 1 to 2, step-down units are 1 to 4. But you go out to the med-surg unit, what type of a workload would you think you'd want to receive as you walked in and looked at the board or looked at your assignment?
2.
Well, okay. What else? Given the acuity, and see, people don't do acuity-based assignments much anymore either. But given the acuity, if you have somebody that needs to have just 2 or 3 patients, you probably need to be in a little bit higher level. And do keep in mind that in order to be admitted into a hospital now, not just, I'm sick, and they drop off grandma with 2 or 3 suitcases because they're going on vacation, she needs a tune-up. But to be admitted now to a facility, you have to have 1 foot in the grave and 1 on a banana peel getting ready to slip. I mean, think of the acuity of the patients you now take care of in a med-surg unit easily were in a step-down unit before, easily. May have even been in an intensive care unit before. And now, of course, there's very stringent guidelines for what really qualifies to be in an intensive care unit. But at the same time, workload is huge. Sandra Feldman, the lady that is the one of the senior people with the American Federation of Teachers, the healthcare division of that American Federation of Teachers, basically had a great quote, and I'll kind of paraphrase it, but she said, common sense would tell you there's only so many patients a nurse can take care of. There's only so many slides that a medical technologist can really read without just being overwhelmed or, exhausted. But she ends it by saying, unfortunately, common sense rarely prevails. And no one, I know as a therapist, no one wants to walk in and be given an assignment they know they can't handle. Routinely given an assignment. In other words, you come in every day and you got an assignment you know you can't handle. How long do you think you're going to stay at that place? Not long. Because it's not in here to do that. And now, let's give a little bit of a disclaimer on that. There's 10 to 15% of the time during any given year, this is one of those times, the flu season has been horrendous. There's about 10 to 15% of any given year that all heck breaks loose. You can't predict it. And I can't even tell you how many times I've sat in a room at 4:30 on a Friday afternoon looking at how we were going to staff the weekend effectively with the rest of the team. And whether it came down to offering, incentive bonuses or this and that, but and then the other thing, you have to be very aware that after 3 shifts, most people can work a 4th shift somewhere during that week, or they can work like an extra shift during the week. And a lot of folks do that. But I can tell you, at about the 9th hour or 10th hour out of your 12-hour shift on any given night, you're starting to drag. And I'll tell you why I know that in a second. The ability to work the extra shifts has to be at least observed by someone like your chief nursing officer, one of your directors of one of the units, for inpatient nursing. And the reason being is it's a safety issue. If you're not on your game, something's going to happen. And you're not going to want it to happen, don't get me wrong. I don't think anybody in this room, at least anybody we've selected here, I can't even imagine they would want anything to happen. Now, stuff does happen, and I'll talk a minute about that, but no one wants to have anything happen to hurt a patient. I know that in my heart. One of the things that can be done is you can obviously have a team that can help out. When you were saying how many patients or whatever, you can have a team that can help out, and usually in facilities of 200 beds or less, the quote float team or float nurse concept works. And what it is you have some nurses that can work either a medical unit or a surgical unit in an ICU, or in other words, they have the competencies to work that unit. And you pay them a little bit more to do that. And the reason you do is because you're going to float them here and there purposely, because you walk in and there's too many patients up there, you got to get some help. And I will tell you that in making effective rounds and going and making rounds, that's one of the biggest things that has to be observed, whether it be from your chief nursing officer, the assistant chief nursing officer, CEO, chief operating officer, whomever, assistant administrator, depending on what type of organization you work with, infrastructure staff, so to speak. But there needs to be someone that cares about what's up there and can look at it from a distance and say, 6 patients on a day shift, that's pretty heavy, especially knowing how acute those patients are. You try to keep it at 5 and maybe the charge nurse will take an admission later. But as it turns out, you need to be aware of that. And I'll give you an example. I made rounds to one day, surgery floor, and saw one of our surgery nurses, and I said, "How's your day going?" Actually, I was working the day shift with them, but I asked them how their shift was going. She said, "I'm having a terrible day." Now, first of all, would you ever say that to the CEO of a hospital? "I'm having a terrible day." First of all, you need to be able to, but how many people do you think do nationwide, okay? And instead of just going and saying, "Well, I'm sorry about," just hang in there and walk off. Why are you having a terrible day? Well, they walked around for 30 minutes trying to find an IV pump for somebody. Couldn't find one. Unit was full, new admission, couldn't find an IV pump. I said, "Well, that's a terrible way." Well, immediately investigated, found out. We always have 10 or 12 of them down in biomed. They're being reprogrammed or broken, or something went wrong with them. There weren't enough pumps. 48 hours later, we had 14 more pumps drop shipped in. Why? Because that's a terrible way for you to spend your day. When you start looking at where you're going to start your career clinically, please be sure there's a number of things in place, and I'm going to get to those in just a minute. Please be sure that where you're going to choose to start your clinical career, you're going to be satisfied and excited about your clinical career. There is nothing more satisfying than what you're going to go do in helping people that are the sickest of the sick, and the patients, and their families. And, everyone, they're scared. Diseases are bad now. You have to be able to understand it. And look at all the technology you have to know. I still have an old stopwatch, 16 drops to a cc. When they started IVs. Now, look at the programming you have in those IV pumps, those Alaris pumps, and some of the other pumps that are out there. Look at your electronic medical record. From Epic to the Meditech one to some of the others. Look at where some of this technology has gone. And by the way, There was a time study done at Terre Haute Regional Hospital in Terre Haute, Indiana, and found that 27% of a nursing staff's time was spent on the computer. Whereas before, it used to be blue ink, red ink, green ink. and you read the notes, but from shift to shift. In fact, the physicians always used to read the nursing, the best ones did. They read the nursing notes because you're the only one that's there 24/7. You're the only one that really knows what went on. You want to find somewhere where you and that medical staff see the same way. You don't want physicians that are walking around and treating you in the way you should not be treated after you've been taking care of their patient for 24 hours. There's a physician, in fact, a good friend of the ghostwriter that helped me transform my dissertation into a book. His name is Dr. David Lavelle. David Lavelle, for the last 25 years, first of all, he's professor of orthopedic surgery at University of Tennessee Med Center in Memphis. And he's been with the renowned Campbell Clinic for 25, 30 years. He said when we select somebody, and here locally, Dixon Medical Associates did the same thing. When they would select somebody, they would get a group of their physicians together, and they would meet and interview and everything with that person. But if one physician just didn't like what they saw, they didn't select that person. So, when you start looking at the selection process, David Lavelle, Dr. David Lavelle, had a great saying. He said, I have a chance, after we select somebody, to meet with those new recruits that we just brought on board to the renowned Campbell Clinic. So you got to know they're pretty selective. And he said, I tell them two things. He said, the first thing I tell them is, I'm a Christian and I believe in God. And the second thing he tells them, you're not him. Period. And when you start looking at you